the huge benefit seen with durvalumab on the Pacific trial in a curative setting has raised the obvious question of whether we can deliver similar benefits and potentially achieve more cures in earlier stage patients still, those with operable disease, whether that is prior to surgery as a neoadjuvant therapy, potentially with chemo, or as a window of opportunity for a few treatments of immunotherapy alone before surgery, or delivering it in the adjuvant setting. And there are several trials looking into this. I think this is extremely exciting. It's an obvious extension of the benefits we've seen in stage 4 and now in stage 3 locally advanced but unresectable disease. And we will need to see much more of this. All we have right now are, we do have a publication in the New England Journal by Patrick Ford and colleagues that looked at neoadjuvant nivolumab, but that was less than 24 patients. It showed at least a proof of principle of a good response seen on major pathologic responses seen in 45% of their patients after just 2 treatments with nivolumab before starting surgery, and then they could go on to whatever after, including chemotherapy as appropriate. This is going to be very well studied. In fact, it's being studied right now in many trials that we will see results on in the coming months and years. I think it's actually quite likely that in the next 3 to 5 years, we will integrate immunotherapies into preoperative or postoperative therapy. But right now, I would say that it remains an investigational option and still the subject of clinical trials, careful discussion with patients, and where it's best studied is unresectable stage 3 along with stage 4. It's been very gratifying to finally, for the first time in my career that goes back now a couple of decades as a thoracic oncology specialist, be able to offer a meaningful benefit beyond what we've been doing since I started doing this, which was concurrent chemo and radiation. We've tried adding more chemotherapy on the back end as consolidation, escalating the radiation, adding targeted therapies in stage 3 unresectable, and all of these have led to no benefit or harm to the patients. And I think some of us were becoming resigned that this is just such a hard nut to crack. Seeing immunotherapy lead to meaningful benefits in an incurable population with stage 4 disease has been gratifying, but it's especially gratifying to see it move into these very difficult areas to treat. Stage 3 unresectable is an extremely common scenario. It's about 1/3 of our patients, and we've just had such trouble breaking that impasse. So having immunotherapy in general and durvalumab specifically as delivering not just a statistically significant benefit, but a striking, clinically significant benefit that we are eager to adopt and is now FDA approved, is extremely welcome, both for what we can offer to our patients now and for the promise of what we think is likely to be available for the future. That this is just the beginning. I think it's an immense, great start after so long banging our heads against the wall, but it's especially great as an omen for the future of integrating immunotherapies into earlier lines and potentially translating the benefits we've seen into more patients being cured of non-small cell lung cancer.